Welcome back to the Deep Dive. Today we are putting on our scrubs, we're scrubbing in, and we're tackling something of an absolute beast.
We really are.
We're looking at one of the pillars, maybe the pillar of surgical literature. We are cracking open Bailey and Love's Short Practice of Surgery, specifically the 28th edition.
A classic. It's that heavy blue book that sat on the shelf of basically every surgical trainee for, the last century?
It is dense, it is detailed, and if we're being honest, it can be a little intimidating.
Yeah.
But we aren't trying to boil the ocean today. We are laser focused on one specific chapter.
Chapter 88.
Chapter 88, Kidney Transplantation and the Principles of Transplantation.
And this is such a great choice because transplantation is, you could argue it's one of the top 3 medical achievements of the entire 20th century.
Absolutely.
It's this high-stakes battle between, on one hand, surgical technicality. Can you actually sew these tiny fragile vessels together, and on the other, the body's own biological defense systems.
Which are just screaming, get this intruder out of here.
Precisely. The immune system is doing its job, but in this case, its job is the very thing you're trying to prevent.
Exactly. So here is our mission for this deep dive. We want to turn this incredibly high-yield, very complex chapter into a kind of ready reckoner.
I like that.
Think of this as your audio revision guide. So whether you're a medical student prepping for finals, a surgical trainee staring down the barrel of the MRCS, or, just someone who wants to know how we can possibly take an organ from one person and make it work in another, this is for you.
But we have to drop a disclaimer right at the start here. This is important.
Right, very important. This is our interpretation and our synthesis of Chapter 88. We are going to use analogies, metaphors, and simplified explanations to help these concepts stick in your brain.
This is not a replacement for reading the actual text.
Not at all.
No. Please don't walk into an exam quoting the deep dive without having looked at the actual diagrams in Bailey and Love. Consider this the scaffolding.
Yeah.
We're building the frame for you. You still have to go read the chapter to put the bricks in the wall.
Perfectly put. So here is the roadmap for the next 40 minutes or so. We are going to follow the life cycle of a transplant kidney from start to finish.
A good logical flow.
First, the supply chain. Where did these organs actually come from? That's donation. Second, the race against time. How do we keep them alive outside the body? That's preservation.
Critical.
Third, the invisible war. The immunology and what we're going to call the car ignition of rejection.
The fun part.
Then fourth, the chemical peacekeepers. The immunosuppression drugs that make it all possible. And finally, the main event, the surgery itself and, of course, the complications.
And for the trainees listening, really treat this like a proper revision session. We're going to have specific check-in points where we'll pause and test your recall.
And if you don't know the answer, just hit rewind. It's that simple.
Exactly.
Okay. Let's start with the supply chain. Part 1, organ donation. The chapter opens with a pretty stark reality when it comes to the numbers. It's a supply and demand problem, isn't it?
Oh, it is a massive gap. A chasm, really. The text highlights UK statistics, but honestly, they're a pretty good proxy for the global situation.
And what are the numbers telling us?
Well, at any given time, there are roughly 4,000 patients on the waiting list for a kidney.
4,000 people.
And the system, with all its efforts, all the campaigns, only performs about 3,750 transplants a year.
So the math doesn't work. You're not even breaking even. The list is always growing.
It doesn't work. That gap creates a median waiting time of about 3 years. And you have to think about what that means. That is 3 years of dialysis, 3 years of fatigue, 3 years of your life just being on hold.
Wow.
So to try and bridge that gap, we rely on 3 main sources of organs. We have living donors, which we'll get to, and then 2 types of deceased donors.
And mixing up these 2 types of deceased donors, well, it's a classic way to fail a surgical exam. So let's be clear. We have DBD and DCD.
DBD and DCVA.
Let's unpack DBD first. It's used to be called heart-beating donation.
Which really confuses people, doesn't it? They ask, well, if the person is dead, how can their heart still be beating?
It's a fair question.
It is. DBD stands for donation after brainstem death. This is a patient who has suffered a catastrophic, absolutely irreversible brain injury. Maybe a massive stroke, a subarachnoid hemorrhage, or a really severe head trauma.
Okay.
They are in what's called an apnoic coma, and they are completely ventilator dependent.
So when we say brainstem death, anatomically, what has actually gone offline here? What's the key structure?
This is your first anatomy anchor. You've lost 2 critical structures in the brainstem. First, the reticular activating formation.
Okay.
This is found in the midbrain, and it basically controls the capacity for consciousness. It's the on switch for the entire brain. That's gone.
And the second thing?
Second, you've lost the medulla oblongata. And this is critical because it houses the respiratory center. So you put those two together, the patient cannot wake up, and they cannot breathe.
But, and this is the key part for families to understand, because the ventilator is physically shoving oxygen into the lungs. The heart, which has its own independent electrical system, it just keeps on pumping.
Correct. The body is warm, the body is pink, they have a pulse. To a loved one at the bedside, they look alive.
Which must be incredibly difficult.
It is. And for that very reason, the criteria for diagnosing this are incredibly strict. You can't just eyeball it. Bailey and Love lists a really rigorous protocol.
It starts with the exclusions, right?
Yeah.
You have to rule things out before you can rule things in.
Absolutely. Before you even think about testing reflexes, you have to rule out any reversible causes. You have to be 100% sure the patient isn't just deeply hypothermic.
Right.
You have to ensure they aren't under the influence of drugs, alcohol, or muscle relaxants from the ICU. You have to check for any severe metabolic shifts like, crazy high or low sodium or glucose that could potentially mimic a coma.
Okay, so all the reversible stuff is ruled out. We are absolutely sure this is a structural, permanent injury. Now, who does the test? Can the transplant surgeon just walk into the ICU and say, yep, looks like a donor to me?
Absolutely not. That would be a massive conflict of interest. The UK guidelines and most international standards are very similar, are very specific. It must be 2 doctors.
2.
And crucially, neither of them can be part of the transplant team. One must be a consultant or an attending, and the other must be a registered doctor for at least 5 years. And they perform the full suite of tests twice, with a gap in between.
And these tests are basically a final exam on the cranial nerve. So let's walk the listener through this. Imagine you're standing at the bedside. What are you actually doing?
You are systematically checking for the total absence of brainstem reflexes. It's usually a top-down approach. You start with the eyes. You shine a bright light in the eyes. You are looking for a pupillary reflex. If the pupils are fixed and dilated, that tells you cranial nerve 2, the optic nerve, and nerve the 3rd, the oculomotor nerve, are disconnected. The circuit is broken.
Then you check the eye sensation, the blink reflex.
Right. You take a wisp of cotton wool and you gently touch the cornea. In a living person, they would blink immediately, an involuntary, powerful blink. If there is no blink, that means nerve V, the trigeminal, isn't sensing the touch, and nerve 7, the facial nerve, isn't closing the eye.
And then comes the one that always sounds the most uncomfortable, the caloric test.
The vestibulo-ocular reflex, and it is uncomfortable to think about. You inspect the ear canal to make sure the eardrum is intact. Then you inject ice-cold water into the ear.
What should happen?
In a functioning brainstem, the eyes would jerk towards the cold stimulus, a type of nystagmus. In brainstem death, the eyes stay completely fixed, staring straight ahead. That clears nerves 8, 3, and 6.
Okay, so that's the eyes. Now moving down to the throat.
You check for a gag reflex or a cough reflex. You use a suction catheter down the back of the throat. If those are absent, you've now confirmed that nerves IX and X are also gone.
So if all of those are negative, no response, absolutely nothing, you move to the final confirmation, the real deal breaker.
The apnoe test. This is the physiological proof. We know the body uses carbon dioxide levels in the blood to drive breathing. If your CO2 goes up, your brainstem screams, breathe.
It's the fundamental trigger.
It is. So what we do is we pre-oxygenate the patient to 100% to build up a good safety buffer. Then we physically disconnect the ventilator.
Or you just wait.
We wait. We're watching the chest like a hawk for any flicker of movement. We leave a small oxygen catheter down the tube for passive oxygenation just to protect the organs, but there is no mechanical breath being given.
How long?
For at least 5 minutes, and during that time, we take a blood gas. If the PaCO2, the level of carbon dioxide in the arterial blood, rises above 6.0 kilopascals, kPa.
Which is a profound acidosis.
A profound acidosis, yes. And the patient has still made absolutely no effort to breathe, then the respiratory center is confirmed to be dead.
At that point, death is legally certified. The retrieval team can finally be called. And the key benefit here is that the organs are perfectly perfused and oxygenated right up until the moment of cold perfusion.
Exactly. They're pristine.
Let's flip to the other side of the coin. DCD, donation after circulatory death.
Right. This used to be called non-heart beating or asystolic donation, and the name tells you everything. In these cases, the heart has actually stopped. There is no circulation at all.
And the chapter references a specific classification system for this.
It does. The Moster-Crape classification,
Hmm.
it categorizes these donors from I to V. But for, exam purposes, you just need to get your head around the main distinction.
Which is?
You need to distinguish between uncontrolled and controlled DCD. Uncontrolled DCD, that's Maastricht categories I and II, these are patients who are, say, dead on arrival at the hospital or who fail resuscitation in the ER. It's chaotic. We don't know exactly when their heart stopped. So these organs have suffered an unknown period of no oxygen.
Which makes them pretty risky to use.
Very risky. Much less common now. What's become standard is controlled DCD, which is category 3.
And what's the scenario there?
This is a patient in the ICU. They have a severe, devastating injury, but they don't meet those strict brainstem death criteria we just went through. However, the medical team and the family have all agreed that further treatment is futile, so they make the decision to withdraw life support.
So it's a planned, controlled event.
Yes. It's very calm, very dignified. They extubate the patient. The blood pressure slowly drops. The heart eventually stops beating. And then comes a really crucial rule, the no-touch period.
How long is that period?
In the UK, it is 5 minutes. Once the heart flatlines on the monitor, the entire team must stand back and wait for 5 full minutes.
Why so long?
This is to ensure there is no spontaneous restart of the heart, the so-called Lazarus phenomenon. It's incredibly rare, but you have to be certain. Only after those 5 minutes of continued asystole can the retrieval team rush in.
And rush is the operative word here. Because unlike DBD, where the heart beat right until the end, these DCD organs are sitting in a warm body with zero blood flow.
Exactly. They are suffering warm ischemia, and that's a key term. Warm ischemia is much, much more damaging to the cells than cold ischemia. It means DCD kidneys are often a bit sleepy or stunned when we transplant them.
Okay. Before we move to preservation, let's quickly touch on the third source, living donation. We mostly think of kidneys because, well, we have a spare one, but the chapter spends some time on living liver donation too.
Which is a technically fascinating but ethically complex area. The liver is the only solid organ that can regenerate significantly, but you're still talking about cutting a large piece of liver out of a perfectly healthy person.
High-risk surgery.
Very. And for the anatomy nerds listening, you need to know your Kuno segments. Bailey and Love has that famous diagram of the liver segments. It looks like a kind of complex puzzle block. If an adult is donating to a child, like a parent to a baby, they usually take the left lateral segment. Anatomically, that corresponds to segments 2 and 3.
And for an adult-to-adult transplant.
The recipient needs a lot more liver mass to survive. So for an adult-to-adult donation, they have to take the whole right lobe. That's segments 6, 7, and 8. A much bigger operation.
And the risk to the donor.
It's not zero. The mortality risk for a living liver donor is about 0.5% to 1%. That's a heavy ethical weight for a surgeon operating on a healthy person who doesn't need surgery, and there's a 1 in 100 or 1 in 200 chance they could die.
Wow.
But the flip side is that the outcomes for the recipient are generally superior to deceased donation because the organ is so fresh and the timing is elective.
Okay, let's pause there. Check-in point number 1. If you're listening to this, I want you to think back to the donor assessment. Can you list the absolute contraindications for organ donation? The situations where it's a hard no.
Think about what you would never want to transplant into another person. Infections and bad cells.
Right, the text lists. Active systemic sepsis.
Yeah.
You can't transplant an infected organ into an immunosuppressed patient.
That's a disaster.
Uncontrolled transmissible infections like HIV, and most malignancies, most cancers, within the last 5 years.
But, and this is the key exam point, what is the big exception to that cancer rule?
Yeah.
Primary brain tumors. Because of the blood-brain barrier, primary brain tumors like glioblastomas almost never metastasize outside the central nervous system. So a patient dying of a primary brain tumor can often still be a fantastic donor for their kidneys, liver, and heart.
That is a brilliant point. Excellent. Let's move on. Part 2. Time is tissue organ preservation. We've got the organ out of the donor. The clock is now ticking loudly.
Yeah.
And the enemy here is ischemia.
This is where we need to understand the cellular power plant. It's a great metaphor. Every cell in our body is like a little city. It needs a constant supply of energy to run.
And that energy is ATP.
ATP, exactly. With oxygen, cells run on aerobic metabolism. It's incredibly efficient. For every 1 molecule of glucose, you get 36 molecules of ATP. The lights are on, the factories are humming, everything works.
But the moment the surgeon puts the clamp on the renal artery, the oxygen supply is cut. The power plant fails.
And the cell has to switch to its backup generators, anaerobic metabolism. This is a terrible, inefficient system. It only yields 2 molecules of ATP per glucose. It's an energy crisis.
And with that energy crisis, the most critical machine in the cell stops working.
The sodium-potassium pump, or Na plus K plus ATPase,
What does that pump actually do?
it's constantly working, pumping sodium out of the cell and potassium in. It maintains a careful electrochemical gradient, but it's very energy hungry. So when it fails, basic physics takes over. Exactly. Sodium rushes back inside the cell down its concentration gradient. And where sodium goes, water follows. The cell literally sucks in water and swells up. We call that cellular edema.
And it gets even worse inside the cell.
Much worse. Calcium regulation fails. Calcium floods into the cell. Calcium acts as a kind of self-destruct signal. It activates enzymes called proteases that chew up the cell's internal skeleton.
So it's collapsing from within.
Right. And at the same time, that anaerobic process is creating lactic acid. The cell becomes acidic. This acidity causes the lysosomes, which are the little garbage bags of the cell, to burst and release digestive enzymes that literally eat the cell from the inside out.
It's a total catastrophic meltdown. So how do we stop this city from collapsing?
We use 2 main tools, cold and chemistry. Cooling the organ down to 4 degrees C is the most important thing. It slows the cellular metabolism down by about 90%.
It doesn't stop the decay.
No, but it puts it in super slow motion. Then we flush the organ with a special preservation solution. The gold standard mentioned in the book is University of Wisconsin UW solution.
And what's in that special cocktail?
Well, it's a very clever recipe designed to fight the physics we just described. First, the electrolytes. It has high potassium and low sodium. This mimics the fluid inside the cell, which removes the gradient that drives the ions the wrong way.
Sure.
Second, it contains imperments. These are large sugar molecules like mannitol or raffinose. They are too big to enter the cell. They sit outside and exert osmotic pressure, essentially holding the water out and stopping that cellular swelling.
So that's static cold storage, the classic icebox method. But Bailey and Love, in the 28th edition, talks about the newer tech, machine perfusion.
This is definitely the future. Instead of just sitting the kidney in a bag of ice, we hook it up to a pump that actively perfuses it.
Okay.
Hypothermic machine perfusion pumps cold preservation fluid continuously through the kidney's blood vessels. It washes out waste products and can reduce the risk of that sleepy kidney phenomenon. The real sci-fi stuff is normothermic perfusion.
So warm perfusion.
Exactly. We keep the kidney at body temperature, 37 degrees, and we pump warm, oxygenated blood through it. We are essentially keeping the engine running outside the body.
That's incredible. Why is that so revolutionary?
Because it allows us to test the organ before we even think about transplanting it.
Yeah.
If you have a so-called marginal kidney, maybe from an older DCD donor, you can hook it up to this machine. If it starts making urine in the box, if its resistance is low, it will almost certainly work in the patient. It takes so much of the guesswork out.
Amazing. Okay, the organ is preserved. Now we have to put it into a new body. And that body is a fortress designed specifically to kill invaders like this. Part 3, immunology.
Right. This is the part that always scares students, but let's break it down into simple steps. The first gatekeeper, the first line of defense, is ABO compatibility.
Blood groups.
The rules are exactly the same as for a blood transfusion. Group O is the universal donor. Group AB is the universal recipient. If you get this wrong, it's a hyperacute rejection, an absolute catastrophe.
Okay, so assuming the ABO groups match, the next thing we look at is the HLA system, the barcodes on the cells.
Human leukocyte antigens. These are proteins on the cell surface that identify self versus non-self. They're like a unique ID card for every person. There are 2 main classes.
Right.
Class I, which are HLA A, B, and C, are on almost every nucleated cell in your body. Class 2, DR, DP, and DQ, are only on the immune system's own sentinels, the professional antigen-presenting cells, or APCs.
And for matching a kidney, we score the match based on 3 of them, A, B, and DR.
That's right. You get 1 of each from your mom and 1 of each from your dad, so there are 6 potential mismatches in total. A 0-0-0 mismatch is a perfect match, like from an identical twin.
And does the book say if one of them is more important than the others?
Yes, and this is a key takeaway from the text. DR is the most important match. A DR mismatch causes the strongest rejection response. An A mismatch is the least important.
Okay, so let's say there is a mismatch. The recipient's immune cells, the T cells, spot this intruder. The text describes the activation sequence. I love the car ignition metaphor for this.
It is the best way to visualize it. For a T cell to get fully activated and launch an attack, it needs 3 distinct signals. Not 1, not 2, but 3.
So what's signal 1?
Signal 1 is the key in the ignition. The T cell receptor, or TCR, recognizes the foreign HLA antigen on the donor cell. It physically binds to it. It sees the enemy.
But if you just turn the key in a car without pressing the clutch?
Nothing happens. In fact, the engine stalls. In immunology, the T cell goes to sleep, a state called anergy. You absolutely need signal 2, which is the safety switch or the clutch.
Okay.
This is co-stimulation. A molecule called CD28 on the T cell must bind with another molecule, CD80 or CD86, on the antigen-presenting cell. That handshake is the safety switch being turned off.
So key is turned, safety is off, the engine can now start.
And that triggers signal 3, which is the gas pedal. The T cell, now that it's got signals 1 and 2, starts to produce a powerful chemical called IL-2 or interleukin-2.
And what does IL-2 do?
It binds to receptors on the same T cell, a receptor called CD25, and it tells that cell to divide. It's the proliferation signal. 1 T cell becomes 2, 2 become 4, 4 become an army of millions of identical clones ready to attack the kidney.
This sequence key, safety, gas, is so critical because, as we'll see, all of our immunosuppressant drugs are designed to target these exact steps.
Precisely.
But before we get to the drugs, one last immunology concept. Direct versus indirect presentation.
Yes, this helps explain when rejection happens early versus late.
How does that work?
Direct presentation. This is when the donor's own immune cells, hitchhikers that came along with the kidney, we call them passenger leukocytes, show the foreign antigen to the recipient's T cells. This happens really early in the first few weeks because those donor cells die off quite fast. This is what drives acute rejection.
And indirect.
Indirect presentation. This is when the recipient's own immune cells come along, find little bits of debris from the donor kidney, gobble them up, process them, and then present those foreign bits. This is a much slower, long-term process. This is what drives the insidious, slow burn, chronic rejection.
Okay, check-in point. If I ask you the timing of rejection based on those presentation pathways, what's the answer?
Direct equals early and acute. Indirect equals late and chronic.
Perfect. If you didn't catch that, just rewind and listen to that ignition metaphor again. It is absolutely foundational knowledge.
It really is.
Right. Part 4, rejection and immunosuppression. The fortress attacks. What does rejection actually look like?
Well, we categorize it by timeline. First, there's hyperacute rejection. This is the stuff of nightmares. It happens in minutes to hours. The surgeon unclamps the blood vessels, and the beautiful pink kidney turns black and flaccid right there on the operating table.
What causes that?
It's caused by preformed antibodies in the recipient's blood, usually from a mistake like an ABO mismatch, or if the patient has been sensitized from a previous transplant or blood transfusion, it causes massive thrombosis. The vessels just clot off.
And the treatments?
There is no treatment. You have to remove the organ immediately. It's lost.
Okay, so that's the immediate one. What about acute rejection in the first few weeks or months?
This is much more common, and it's divided into 2 types. First is acute T-cell mediated rejection, CMR. This is when the T-cell army we talked about invades the kidney tubules. On a biopsy, the key finding is tubulitis. We treat this with high-dose steroids.
And the second type?
Acute antibody-mediated rejection, AMR. This is when the B cells get involved and make antibodies against the kidney. The biopsy shows a special stain called C40 in the capillaries. This is generally harder to treat. We might use things like plasma exchange to wash the antibodies out.
So to stop all of this from happening, we use the drugs. Let's map the drug arsenal back to the car ignition signals we just learned.
Good idea. So first you have induction agents. This is the big hit of immunosuppression you give right at the time of surgery. A common one is basiliximab.
And what does that do?
Basiliximab is a monoclonal antibody that physically blocks the IL-2 receptor, CD25, so it puts a padlock on the gas pedal. Even if the T cell produces IL-2, it can't bind and can't proliferate. You're blocking signal 3.
Okay, that's the induction. What about the long-term maintenance therapy, the famous triple cocktail?
Right, it's like a 3-legged stool. The first leg is a calcineurin inhibitor, CNI. These are drugs like tacrolimus or cyclosporin.
Their mechanism.
They block the production of IL-2. They cut the wire between the ignition, signal 1, and the engine. A very powerful effect. But they have a major side effect.
Which is?
Paradoxically, they are nephrotoxic. So the very drugs we use to protect the kidney actually damage it slowly over time. They also cause things like tremors and With cyclosporin, significant gum hypertrophy.
Okay, that's leg 1. Leg 2.
Leg 2 is an antiproliferative. Drugs like mycophenolate, MMF, or azathioprine, these are essentially chemotherapy agents that stop DNA replication. So even if the T cell hits the gas, its wheels can't turn because it's physically unable to divide and create that army.
Side effects to watch for there?
Bone marrow suppression. You have to keep a close eye on the patient's white cell count.
And the third leg of the stool.
The old classic, steroids. Prednisolone. This is the sledgehammer. It's a broad, non-specific anti-inflammatory.
With the well-known side effects.
Oh, yes. Cushing syndrome, the weight gain, diabetes, thin skin, cataracts. It's why we're always trying to reduce or stop the steroids if we can.
The text also mentions an alternative class, the mTOR inhibitors like sirolimus. Where do they fit in?
They're interesting. They block the response to signal 3. So the IL-2 is made, it binds, but the cell doesn't get the message to divide. But here is the big warning label from the book. Sirolimus impairs wound healing. You never, ever give it immediately after surgery, or the incision will just fall apart. It's a drug you might switch a patient to later on, but not in the early post-op period.
Got it.
Right.
Okay. Part 5, the procedure. We've done the science. Now let's pick up the scalpel. To make this real, let's use a fictional case study.
Good idea.
Let's meet Mr. Jones. He's 60 years old. His diagnosis is polycystic kidney disease, or PKD.
Ah, good choice.
Yeah.
Because PKD presents a specific surgical challenge right from the get-go. His own native kidneys are not the normal fist-sized organs. They're full of cysts, and they might be the size of rugby balls.
Literally filling his abdomen.
Now, normally in a standard transplant, we leave the old shrunken kidneys in. We don't touch them. We just put the new one down in the groin. But with Mr. Jones, his abdomen might be so full of these giant cystic kidneys that there's simply no room.
So what do?
He might need a native nephrectomy first, either before or at the same time as the transplant, just to clear a parking space for the new kidney.
Okay, the space is cleared. We are in the operating room. Where does the new kidney actually go?
It's placed heterotopically, that's a key word. It means in a different place from the original. We place it in the iliac fossa, which is the little bowl of the pelvis, and it sits outside the main abdominal cavity in a space called the retroperitoneum.
Now for the plumbing, there are 3 connections to make: vein, artery, and ureter. Let's take them one by one.
Okay. First, the vein. We sew the renal vein from the new kidney end to side onto the recipient's external iliac vein.
Next, the artery.
Second, the artery. Usually this is also end to side onto the external iliac artery, or sometimes end to end the internal iliac artery.
Now wait, before we sew the artery in, Bailey and Love talks about something called bench surgery, checking the donor kidney on the back table.
This is a crucial step. Kidneys, they don't always come with just one artery. Sometimes they have multiple little accessory arteries. If you see a small accessory artery going to the lower pole of the kidney, you must save it. You have to reimplant it. You cannot just tie it off.
Okay, here's a check-in point. Why is that lower pole artery so absolutely critical?
Because in a transplanted kidney, which has been removed from its normal blood supply, the lower pole artery is often the only blood supply to the ureter. In your native kidney, the ureter gets blood from everywhere, the aorta, the iliacs. But in a transplant, it's a single fragile supply line. If you cut that lower pole artery, the ureter becomes ischemic, it turns black, it dies, and a few days later it will leak urine all over the inside of the patient, a disaster.
Got it. So vein is done, artery is done, the clamps come off, the kidney turns pink, hopefully. Now for the final connection, the ureter.
The last bit of plumbing. We need to connect the ureter from the new kidney to the patient's bladder. The standard technique described is the Lich-Gregoire technique.
And what does that involve?
It's an extravesical onlay. It's clever. We make a cut in the thick muscle of the bladder, but we leave the inner lining, the mucosa, intact. We then make a tiny hole in the mucosa and sew the ureter to it. Then we close the thick muscle over the top of the ureter, creating a tunnel.
Why create that tunnel? What's the point?
It acts as a brilliant, simple, one-way valve. When the bladder fills up and squeezes to pee, the muscle clamps down on the ureter in that tunnel, stopping urine from shooting back up into the new kidney. It prevents reflux.
And you usually leave a stent there for a while.
Yes, we almost always leave a little plastic tube called a double J stent running from the kidney, down the ureter, and into the bladder for a few weeks, just to keep it all open while it heals.
Okay. Part 6. Complications and outcomes. The surgery's done. Mr. Jones is in the recovery room. What are the things that keep the transplant surgeon awake at night?
Oh, the early complications are the scariest. First, hemorrhage, a blowout of one of the vascular anastomoses. It's rare, but it's life-threatening.
And clotting.
Thrombosis, specifically renal vein thrombosis. This is a bad one. The kidney swells up, it becomes very tender. On an ultrasound scan, the radiologist will see a sign called reversed diastolic flow. This almost always means the graft is lost and has to be removed.
What about fluid coming out of the surgical drain? How do you know if it's a urine leak or just a lymph leak?
Great question. A classic exam scenario. To tell the difference, you send a sample of the drain fluid to the lab and you ask them to measure the creatinine level.
And what do the results tell you?
If it's lymph from a cut lymphatic channel, the creatinine will be the same as the patient's blood serum level. But if it's urine from a leak, the creatinine level will be massive, maybe 10 or 20 times the serum level.
And what about delayed graft function, DGF?
Yeah.
We mentioned DCD kidneys can be sleepy.
This is when the kidney is stunned from the ischemic injury. It just doesn't wake up and make urine. So Mr. Jones needs to stay on dialysis for the first week or so after his transplant. It's essentially a form of acute tubular necrosis of the new kidney. It's very common in DCD kidneys, but it usually recovers with time.
Okay, moving on to the late complications, things that can happen months or years later. The text mentions lymphocele.
A lymphocele is just a big collection of lymph fluid that can build up around the kidney and sometimes compress the ureter, causing a blockage. The treatment is usually to create a window in it so it can drain into the main peritoneal cavity, a procedure called fenestration.
And there's a specific vascular issue to look out for. Transplant renal artery stenosis, TRAS.
Right. Mr. Jones comes back to your clinic 6 months later. His blood pressure, which was well controlled, is now sky high, and his creatinine is slowly creeping up.
Red flags.
Big red flags. You do a Doppler ultrasound of the kidney, and the classic sign you're looking for is something called the tardus parvus waveform.
Tardus parvus.
It's Latin. Tardus means late or slow rising, and parvus means small or low amplitude. It's a dampened waveform that tells you there is a tight narrowing, a stenosis, upstream in the artery, which is restricting the blood flow.
Finally, let's talk numbers. What is the real-world outlook for Mr. Jones and his new kidney?
We talk about half-life in transplantation. That's the time until 50% of the transplanted grafts have failed.
And what are the figures?
For a deceased donor kidney, the half-life is about 15 years. But for a living donor kidney, it's significantly better. The half-life is around 25 years.
That is a massive difference.
A whole decade.
It is. A living donor kidney effectively buys you an extra 10 years of freedom from dialysis. That is why we advocate for it so strongly whenever possible.
Okay, let's bring it all home. We've covered the stark gap in supply and demand, the incredibly rigorous two-doctor testing for brainstem death, the cellular power plant failure of ischemia,
The car ignition signals of T cells.
the drugs that are designed to jam those signals, and the delicate life-saving plumbing of the iliac fossa.
It is a dense chapter, for sure, but it's a beautiful one because it brings together pure physiology with some really high-stakes, elegant surgery.
If you are a student listening to this, go grab the book now. Look at figure 88.6, which shows the immune signals. That visual is absolute gold. And find the diagrams of the Lich Gregoire and anastomosis for the ureter. Yes. And maybe leave with this final thought. We mentioned normothermic perfusion, that warm machine that keeps the kidney alive outside the body.
Right.
The entire field of transplantation is slowly shifting its mindset. We're moving away from asking, is this organ perfect? And towards asking, does this organ function?
A much more practical question.
A much more practical question. And by being able to test drive these so-called marginal organs on a machine, we might be able to safely use thousands of kidneys from older or more complex donors that we currently, sadly, have to throw away. That technology could be the key to finally clearing that waiting list.
A very hopeful note to end on. That's it for this deep dive into Bailey and Love Chapter 88.
Keep reading.
Keep learning, stay curious. We'll see you next time.